Recording stopped.
Good morning.
Recording in progress.
Welcome to the second Asia Pacific Myopia Society Congress. The APMS was established in 2016. The APMS is fully committed to fostering developments in preventing and treating myopia in the Asia Pacific region and beyond. We held our first ever Congress in 2019 in Shanghai. Unfortunately, physical congresses are impossible at present due to the pandemic. However, to continue our mission, we decided to resume our Congress activity using the virtual format. We are very honoured to have leading international myopia experts to present the cutting-edge findings in our 7 comprehensive scientific sessions. I hope you all will enjoy our one-day Congress. Thank you.
Hello, everybody. Thank you so much for joining us today. This year, we have over 30 speakers to share their latest innovations and discoveries in the myopia field. I would like to take this opportunity to thank all of our section chairs and speakers, especially those from the West, for agreeing to participate in our live panel discussion in spite of the time zone difference. This year, we have established our first international award lecture to recognize individuals who have made significant contributions to the science, understanding, prevention, and treatment of myopia. Please stay tuned till the end of today's program for the International Award Lecture. Unity is power. When all of us come together and exchange the latest discoveries, knowledge, and developments, we can move forward and create a new chapter in the field of myopia. Let's have a round of applause for all of us. And without further ado, we will start our scientific program. Our first sections will be on SMILE, chaired by Joe Matter from Singapore, Kelvin Wen from Hong Kong, and Yan Wen from China.
So I'd first of all like to thank the organizing committee for this kind invitation to talk at the second APMS conference. My title of my talk is Long-Term Reinnovation, Comparing SMILE to LASIK. These are my financial disclosures. They really just pertain to Carl Zeiss Meditech, who developed the SMILE procedure. So SMILE is an acronym for small incision lenticle extraction, and it's a keyhole procedure where lenticle is removed from a small incision on the surface of the eye. And there's several benefits of this smaller incision, but one of the key advantages could be less dry eye for the patients. You can see in this picture below of 2 of my patients, one eye had LASIK, one eye had SMILE. And typically when you see at 1 month, if you do some fluorescein staining, you'll see the inferior punctate epitheliopathy in the LASIK eye, which is missing typically in the SMILE eye. Years ago, we wanted to study the reinnovation in a rabbit model of refractive surgery. And you can see in the 2-week postoperatively, there is denervation in both the SMILE and the LASIK eye in the central area. But when you follow these rabbits out for 8 weeks, you can see faster reinnovation in the central area of the rabbit eyes in the SMILE procedure following the LASIK procedure. Subsequent to our paper, there have been several studies in the literature comparing clinical outcomes to SMILE versus LASIK, typically using Cauchy-Bonnet for corneal nerve sensitivity or other objective measurements such as Schirmer's and tear breakup time and osmolarity. And most of these studies have actually been all in favor, showing faster recovery in SMILE eyes compared to LASIK eyes. However, if you follow the patients up, most of the studies have actually only have follow-up up to 6 months. So one of the questions is what happens after this time period? Is this advantage that the SMILE eyes have at 6 months maintained in the longer term? And does this early denervation make actually any difference in the longer term at all? A few years ago, we did a randomized controlled trial, and this was a paired eye study where one eye underwent SMILE, one eye underwent LASIK. The results of the study were published in 2020, and they showed there was no significant difference in the refractive outcome of these patients. So what we did was that we brought these patients back that were originally in the study, and since these are a very unique, basically, group of patients because they've had SMILE in one eye and LASIK in the other eye, they act perfectly as an internal biological control. So we had 24 patients, 12 in group 1, which is between 2014 and 2016, which is an average of 2.7-year follow-up, and 12 in group 2, which is between 2012 and 2014, with an average of 5.5-year follow-up. They all underwent IVCM, and we examined 5 areas of each cornea: the central, superior, inferior, nasal, and temporal. These are analyzed using some special software, and we compared them to 6 age-matched controls, i.e. 12 eyes. The patients also underwent clinical assessment, typically looking for objective measurements, but also subjective measurements using the OSDI questionnaire. The analysis of the in vivo confocal images, as you can see typically in figure A over here, was done using a manual software, so CCM Matrix, which basically allows you to outline the corneal nerves and the branch points, which you can see over here with the green dots. There's also an automated form of the software as well that allows this to be done quicker, using called ACM Matrix. And in total, there were 1,707 images that were analyzed from the 20 patients. So the parameters that we looked at, we were able to obtain 4 parameters from the CCM software, which is the manual software. These include nerve fiber density, length, branch density, and nerve fiber tortuosity. We're also able to assess them qualitatively for sprouting and beading, and the ACM Matrix software gave us another 4 parameters, including branch density, nerve fiber area, nerve fiber width, and also basically factorial dimensions. And from the picture over here, you can see typically examples of LASIK patients in group 1, so the shorter follow-up versus the longer follow-up, SMILE in group 1, and also basically our age-matched control. If you look at the subjective and objective measurements, you'll see there's no significant difference with respect to examination of clinical parameters between the SMILE and the LASIK eyes. And these are all p-value of greater than 0.05 at the final endpoint. The comparison between the 2 groups at a mean follow-up of 4.1 years showed that in the LASIK eye, there was significantly less nerve fiber density, branch density, nerve fiber length, in the whole cohort, comparing the 2 groups. And also we were able to show that SMILE showed significantly less beading than LASIK, and this is basically because of a beading response related to the nerve damage causing by axonal enlargement. And this was much more common, i.e. greater loss of subbasal nerves in the LASIK group compared to what we're able to see in the SMILE group. If you look at just the SMILE group now and you compare group 1, which is a shorter follow-up, versus group 2, which is a longer follow-up, you can see that the sprouting of the nerves, the nerve fiber branch density, nerve fiber length, was significantly higher in group 2 compared to basically group 1. So that shows you that even at 5 years follow-up, there is still active regeneration going on following the surgery. However, if you compare this to age-matched controls, even at 5 years, this is significantly lower compared to the comparative group. If we look at LASIK, again, you see a similar picture where all these parameters were significantly higher in group 2 than group 1. So it shows, again, you're getting active nerve regeneration even up to basically 5 years follow-up. And all of these were significantly lower in the LASIK group compared to age-matched control, even at 5.5 years follow-up. Now, if we compare amongst the groups, so SMILE in group 1 versus LASIK in group 1, you will see that the fiber density, branch density, fiber length, and also total branch density was significantly better in the SMILE group compared to LASIK group, and this was at an average of 2.7-year follow-up. And then if we look at the longer follow-up group, the 5.5 years, the fiber density and branch density was significantly still better in the SMILE group compared to the LASIK group, albeit the parameters were much closer together because there is some regeneration at 5.5 years itself. And also importantly, the beading was significantly less in the SMILE group compared to the LASIK group. If you plot all these parameters out and you draw a line of equivalence, you'll see that the majority of the parameters all basically favor in front of SMILE, typically more so obvious in group 1, but also basically a lot of parameters in group 2. The ones that are below the line, the ones that basically favor LASIK, typically we saw these parameters in the patients that actually were low myopes, where there was either equivalence or slight favor of doing LASIK over basically doing SMILE. If you plot this out against spherical equivalent, this is quite important. So this shows the huge advantage of SMILE, especially at moderate to higher degrees of myopia, where there is minimal correlation with respect to nerve fiber density in the SMILE group, but with LASIK group, there's significant correlation in relation to spherical equivalent. So the higher the spherical equivalent, the greater the corneal, the denervation in the LASIK eyes compared to what we're basically seeing in the SMILE eyes. So in conclusion, published clinical studies have shown advantage in nerve reinnervation in SMILE compared to LASIK, but only up to 6-month follow-up. This cross-sectional study is the first study that's basically shown longer follow-up, and we compared it to a matched, age-matched, refraction-matched population. There was no significant difference in clinical parameters between SMILE and LASIK with respect to objective and subjective measurements, and this shows you really that the fact that our clinical parameters are really not sensitive enough, and this is really up to a mean of 4.1 years. However, in vivo confocal microscopy showed significantly less nerve fiber density, branch density, nerve fiber length, and total branch density in LASIK compared to SMILE, and there was significantly more beading in LASIK compared to what we were able to show with SMILE. Even at 5.5 years follow-up, SMILE was better than LASIK in the majority of the eyes, the exception being those with low degrees of myopia, but this was still significantly less than age-matched controls. Thank you for your attention.
I would like to share with you how to get started in SMILE, from cases selection, treatment parameters design, as well as the techniques involved. I would like to acknowledge my co-worker, Shelley, Andy, and Jesse. From SMILE versus LASIK all the way to things that we need to pay special attention to. SMILE in some parts of the world, such as China, has become the mainstream and benchmark for refractive surgery. Patients feel more comfortable, surgeons feel safer, and then the wound is smaller with greater corneal integrity. SMILE is a flapless procedure, and the flap-related complications to a large extent will be eliminated. However, it still can have wrinkle, DLK, epithelial ingrowth, infection, etc. There is less post-op dry eyes. Nevertheless, you still have cases that have a moderate to severe dry eyes. So we still need to take care of that. And the cons for SMILE are: number one, no tracking system; number two, slower visual recovery; and number three, this intracorneal manipulation is quite something different. And then the treatment will be more difficult, and the refractive correction, the range at the moment is still a little bit limited. So a safe transition is very important, no matter you're already a LASIK surgeon or you start from zero. So this learning SMILE surgery could be quite challenging. A systematic approach will ensure a smooth and safe transitions. Regarding the SMILE workshop, we have 4 major components: from eligibility, contact lens history, the refraction, as well as the parameters selection. So here we are. We want to make sure that there's no severe dry eyes and that the risk of keratoconus has to be properly assessed. And then we want to make sure that the pupil size is not too big relative to the treatment, and then the corneal thickness is good enough. So for the treatment zone, ideally, the treatment zone should be larger than the scotopic pupil size. However, if this is not adequate, international wise, you can reduce the treatment diameter 0.5 millimeter less than that of the scotopic pupil size, but you have to make sure that this diameter is already 0.5 millimeter larger than the mesopic pupil size. If you can do that, the risk of having post-op suboptimal visual quality will be very low. The ablation thickness is also very important. If the lenticule is too thin, then the risk of complications from tearing, perforation, so on and so forth will be high. So we can make adjustment so that we can make the lenticule thicker. Key treatment parameters. Number 3 is residual thickness. We want to make it more than 250 micron. This is according to the size recommendations. The total thickness from the cap plus the back is 380 micron. So when you have suboptimal setting, for example, when the stromal bed is less than 250, then you want to consider cross linkage, and the residual total corneal thickness is between 350 and 380. So in these circumstances, the cross linkage will reduce the risk of postoperative keratoconus. Now, preoperatively, you want to mark the location of the angle cover, as well as you want to have the horizontal alignment so that when there's cycle torsion, you can make a proper adjustment. Intraoperatively, the head position is important, and also before finishing, checking whether the lenticule is complete or not is extremely important. You have to know your machine, and then the setting is already very important. We have the name of the patient and their refractions put up over there. We have the corneal marking maps as well as the angle cover map. So we will feed in the data. Double checking this data is extremely important. We have, this silly mistakes if you enter it correctly, then this will be a big disaster. Patient cooperation is very important, so you have to communicate adequately with the patient, including ask the patient to keep a chin down position, so that when the chin is moving towards the laser machine instead of moving away from it, reducing the risk of such a loss, and then keep the head steady and stay at the green light in the beginning. So docking and then lenticle separation and extraction. Regarding docking and laser applications, patient cooperation is extremely important. And then you want to make good centration, avoid suction loss, and make sure the interface is really clean. And astigmatism, you may have to adjust the laser ablation positions. So lenticle separation and removal. So we have, from smooth cases to cases that have complications. Here you can see that the usual procedures is to separate the anterior layer and the posterior layer, and then remove the lenticle. Suction loss is a major complication. We should try our very best to avoid this from happening. During the laser ablation, it's about 25 seconds. You want to complete that as soon as possible. Keep a close eye at the monitor or through the operating microscope. Once you have suction noise, you have to stop the machine, and then you ask the patient to keep a chin down position, and then warn the patient before laser ablation that blurring of vision or even black out during laser is normal, and don't try searching for the green light. Because once the patient tries searching for the green light, then the eye will move and then there will be suction loss, and then ask the patient to keep both eyes open. For the interface, the debris can be coming from the surface of the cone. So here we have some cottonite, and then you have to remove it. For small debris that are far away from the center, you may still proceed, and the separation and removal of the lenticle usually is not a big issue. And sometimes, say here, you have some black marks, so usually coming from the grease. This may cause some difficulty in the separation. And for this one, actually, the patient has some mechanical trauma to the corneal surface, to the epithelial surface, leading to very difficult separations. So sometimes the shadow, you can see a shadow, but actually this is not over the cornea. It's in the iris plane in this case. For astigmatism, if this is 0.75 diopters or more, we have to mark the cornea preoperatively, because we know that there's rotation. There is cycle torsion arising from the change in the position. So here you can see that we adjust the position of the cone so that the alignment is proper. We have compensated for this cycle torsion, and then the astigmatic correction effect will be optimized. If we have to use a larger size cone, then we have to pay special attention, because some of the patients will have these peripheral corneal neovascularizations because of contact lens wear, and then there will be bleeding, and then the laser may not be able to get through. Under such a circumstance, you may use a blade to mechanically make open the incision. So we have shown you some photos about the debris. So here, this one is quite small and quite peripheral. You can see that we can proceed, with a little bit of difficulty, but not too much. So we can still finish the surgery. But even better, you remove the debris before you proceed with the laser ablation. If the interface effect is great, and then the laser ablation is not that thorough, we can have a condition like this. So it's very difficult to separate, especially for inexperienced surgeon. Under that circumstance, we can stop the surgery, and then we can seek the help of a more experienced surgeons. So in this case, the anterior segment OCT show that actually, there is folding of the lenticle. So it's with the help of an experienced surgeon that finally the separation was completed, and then the patient get a good visual outcome. So I think it shows you quite adequately that you have to make the median clear, make sure that all these interface debris or grease or whatnot have to be removed properly. This particular patient actually has some mechanical trauma over the epithelium, so that all this fold, number one, reduce the thoroughness of the laser ablation, and number two, this can cause uneven laser ablation and finally lead to poor visual outcome. So after trying this for a while, we decided that we should stop the surgery, and this patient got excellent result with a TPRK. Extension of the wound and tear of the caps are also relatively common, especially in the beginning of the surgery, because the cap thickness is between 90 and 140. So try to be as gentle as possible. And also, when you are having instrument inside the lamellar space, you have to be very cautious. Otherwise, as shown in this case, you can create a large radial tear. And this tear, goes almost to the visual area. So all these are avoidable from concept to your, gentle handling or manipulation of your instruments. We reduce the risk. When you have low refractive errors, you can increase the thickness by increase the minimum ablation thickness. The treatment diameter, you can get it bigger, and then use a thicker cap. So we would, advise you to be very gentle and then check the lenticle completeness at the end of the surgery. So you can see that for this one, it's a low myopia, and then there is a tear of the lenticle. It was noticed during the surgery, and then we check and double check, make sure that all the fragments have already been removed. And for this particular case, the fragment was noticed only when we check this. The surgery appears to be very smooth, but when we check this before finishing, we find that there is a notch over there. Fortunately, the fragment was removed at the same time. And sometimes, it's not noticed. For example, everything was smooth, and then it was removed, and then we check this, and then find that it's not complete. Yeah, so his piece is left behind, and then we go back to do a more thorough separations, and finally we remove the piece, and then we match this and make sure that it's all removed before you finish. However, in cases that very tiny fragment at the peripheral parts can be left behind, you really cannot remove that, because the visual and optical effect will be very minimal if this is small and over. A systematic approach to these SMILE transition is very important. You have to have the good basic knowledge. The bookwork is important, and then wet lab training. And before you move on to the operating theater, comprehensive SMILE workup, so that you select the right patient and then design the right parameters for your patient. You have to be under supervision, hands-on training, at least 10 to 20 hours. And even though your trainer feels that you are already good enough to do it independently, in the beginning cases, it's important for you to have backup surgeon who's around and can go into the operating theater anytime when it's needed. In conclusion, SMILE will become the mainstream of refractive surgery. This is a different surgery when compared to that of LASIK, so it could be challenging. Systematic and comprehensive SMILE workup is very important, and systematic training will make the whole transition safe and effective. Thank you.
Thank you very much to the Asia Pacific Myopic Society for organizing the virtual APMS Congress. I'm very thankful for the organizer for inviting me to give a talk on dry eyes after SMILE. So why is dry eyes important after SMILE? Well, it's one of the most common complications after refractive surgery. Nearly half of the patients will have some sort of tear dysfunction signs and symptoms at the first weeks postoperatively. Fortunately, the majority of them will resolve by about 6 to 9 months. Despite being a very short-lived complication, in a small minority of these patients, they can have some very severe symptoms, leading to patient dissatisfaction. So what are some of the mechanisms behind dry eyes after refractive surgery? To understand this, we need to know the cornea anatomy. Now the corneal nerve bundle enters from the periphery towards the center in a radial fashion to form the subepithelial nerve plexus beneath the Bowman membrane. These nerve bundles then penetrate the Bowman membrane to form a subbasal nerve plexus, giving rise to terminal nerves in the deep epithelium. Now, depending on your surgical skills and also where you're practicing from, the small incision in SMILE can range from 2 to 4 millimeters for removing the lenticule, and the incision can damage the subbasal nerve plexus in this area. Now, this is a much smaller incision than femtosecond LASIK. Despite the small incision, this can cause cornea sensation impairment, affecting the blink reflex. Here you can see from this photo at the top are the before and changes image after LASIK, and at the bottom in SMILE, taken using a confocal microscopy. We can see that there's a greater reduction in the cornea nerve fiber density, branch density, fiber length, as well as the cornea nerve fiber fractal dimension in LASIK compared to SMILE. Studies have found that the loss of cornea nerve fiber length correlates with dry eye parameters. Furthermore, after a laser refractive surgery, it also induces low to mild inflammatory responses, which is involved in post-operative wound healing. Now, these inflammatory processes will further cause pro-inflammatory mediators to be released, such as MMP9. And MMP9 has been shown to correlate with the dry eyes as well as degradation of the ocular surface. Now, during the suction cone applications, despite not for very long, this can actually damage the goblet cells. And the goblet cells are responsible for the mucin layer of the tear film through the secretion of the glycoproteins. Another mechanism is due to the applications of intraoperative and postoperative eye drops, which contains preservatives such as BAC. And BAC has been shown to increase tear film instability and evaporation through dissolving the lipid layer. And furthermore, BAC can also damage goblet cells and microvilli. Now that we understand the mechanisms behind dry eyes after refractive surgery, what does some of the evidence say when comparing SMILE with LASIK for dry eyes? There is limited evidence beyond 6 months to study dry eyes. For example, one study followed up patients after LASIK and SMILE for up to 3 years. In this study, the author found that SMILE took 3 months for the dry eye symptoms to recover, compared to LASIK, which took 6 months. And for tear breakup time, it took 6 months for SMILE to recover to preoperative level, and it took almost a year for LASIK to return to these preoperative level. However, from 12 months onwards, there were no differences in terms of these parameters. Now, in understanding or comparing these parameters within the first 6 months, it's important to look at the different time periods. In a review published by my colleagues and I, we looked into the different dry eye parameters at different time points. Now you can see at first week post-operatively, in the studies that have reported dry eyes outcome, there were no differences at the 1 week time point. However, at the other time points, such as 1 month, 3 months, and 6 months, across various parameters, such as the ocular surface disease index, tear breakup time, Schirmer test, and tear osmolarity, the majority of the studies have found that these parameters are worse in LASIK compared to SMILE, whereas the other studies have found there were no differences between the two types of laser refractive surgery. Now, this also corresponds to the changes that we see in confocal microscopy. Likewise, in a similar manner, we found that the cornea sensitivity is worse after LASIK compared to SMILE in most of the studies that have reported this outcome. And in terms of the subbasal nerve plexus, one study found that LASIK has worse density at the first month, whereas another study reported there were no difference at 6 months. So how do we find patients? How do we identify patients that are at risk of developing dry eyes after refractive surgery? Well, there are some simple things we can do at our clinic. One is to use a standardized dry eyes assessment form, which is the OSDI or the SPEAK questionnaire, to identify those patients that have a moderate to severe grade dry eyes. Furthermore, we can take a history to understand whether they have any contact lens intolerance, and those patients with a long-term contact lens are more likely to develop dry eyes after SMILE. And it's important to study the tear film preoperatively because there's a strong association between the preoperative tear film instability level and the postoperative level. And studies have found that the the reduction in the cornea sensation is particularly reduced in patients with a poor tear film stability preoperatively. And it's also important that we take a Schirmer's test to ensure that the level is normal. And in some scenarios, we may also consider taking the tear osmolarity as well as the MMP9 levels. Because if we look at the ASCRS recommendations in identifying those patients with ocular surface disturbance after cataract surgery, these point of care devices has been a big part. In fact, it's actually done very early in terms of assessment. So they could also potentially play a role in preoperative assessment for dry eyes for refractive surgery too. For those patients that are at risk of developing dry eyes afterwards, we can also consider giving a course of cyclosporin A starting 1 month preoperatively. And because this medication has a minimum duration of onset, so it's better to start this medication preoperatively and continue for about 3 months. And studies have found using this regime, it leads to better Schirmer test scores and also refractive results, as well as a greater improvement in cornea sensitivity in LASIK patients. Also, in patients with a reduced tear break time and Schirmer test, one may also consider ribimapide. But of course, this medication would increase the cost of the surgery substantially, but it can be considered in those patients with dry eyes. And in recalcitrant cases, we may consider also diquofusel given post-operatively. And in those patients with severe symptoms, we may also consider a course of vector thermal pulsation, as it has been shown to improve the dry eye parameters in recalcitrant cases. So to summarize, the mechanisms of dry eyes is multifactorial. It's important to identify patients at risk and offer targeted treatment. Thank you.
The topic is the retrospective study of long-term visual quality and stability after corneal refractive surgery. I'm Dr. Fengju Zhang from Beijing Tongren Eye Center, Beijing Tongren Hospital of Capital Medical University. This presentation have no financial interest. As we know, the prevalence of the myopia have increased very much. And every year in China, more than 1 million people receive the corneal refractive surgery. What we consider is about the long-term stability and the visual quality and the binocular visual function. So we do the retrospective study to verify the satisfaction results and quality and stability. First, these patients have received their corneal refractive surgery more than 5 years. The age is the 18 to 35. The refraction is -3 to -12. And the indication and the contraindication according to refractive surgery, PPP, and consensus in China. Totally, we included 76 patients and divided into 2 groups. One is the aphasic group, totally 38 patients, 76 eyes, and the SMILE group also comparable. Pre-operation, the data is more comparative between the 2 groups. On the age, best correct visual quality, refraction, and corneal pachymetry. And after surgery, 5 years, let's say the 2 groups also show no significant difference on the uncorrected visual acuity, refraction, and biomechanical intraocular pressure and central corneal thickness. We also checked the fundus for these patients. The table 3 show the quite more percent in moderate myopia both in after LASIK group and the SMILE group, 21.05% and 23.68%, and only small percentage in the high myopia. That means we should pay more attention on the moderate myopia after the long-term surgery. And also we check the retinal degeneration in both groups, and the retinal hole totally account 28.95% in LASIK group and 26.31% in SMILE group. And we also check the corneal epithelium thickness and corneal pachymetry. There are no difference between the two groups. And also there are no significant difference between two groups in macular retinal thickness. As for the corneal biomechanical response, we use the new version Converse ST to check the CBI LVC. There are no significant difference between two groups. As for the corneal biomechanical parameters, also there are no significant difference between two groups in SPA1, ARTH pachymetry, and integrated ratio, 1 mm DA ratio and 2 mm DA ratio. Also, we check the subjective quality of visions. In both groups have very high satisfactory rates. In LASIK group, 92% and 94% in SMILE group. The result quite good. Let's look for the LASIK group. There are 3 patients with moderate myopia. They complain of the decline in accommodation with the aging. We look at the 2 patients with high myopia in SMILE groups. Both of them complain of the myopic regression. Since before the surgery, the patients have a high myopia. And another patient complain of the difficulties at night when driving. Let's see the regression rates. Both groups, the patients belong to the high myopia. And the regression rates between the minus 0.5 and the minus 1 more account in SMILE groups compared to LASIK. And much more regression rates in high myopia in LASIK group, more than -1 diopters. As for the accommodative functions, there are no significant difference between two groups. We check the high order aberration. Let's see, there are significant difference between two groups in coma, spherical aberration, and the trefoil. From the finger, we can see the coma, spherical aberration, and trefoil is quite lower in SMILE compared to LASIK, but the trefoil is much more high in SMILE group. And as for the OSI and the tear film, the result from the SMILE group quite good compared to LASIK group. Anyway, there are no difference between the two groups in MTF cutoff. As for the contrast sensitivity, in the 3 spatial frequency and 18 spatial frequency is a little bit high in SMILE groups compared to the LASIK group. As for the scotopic contrast sensitivity and the glare sensitivity, there are no significant difference between two groups. So from this result, we get the conclusion. The patients received the corneal refractive surgery after the 5 years long-term follow-up. The results showed both after LASIK group and the SMILE group were equal, effective, and safe in individuals among 18 years to 35 years with moderate to high myopia. The corneal biomechanical stability was similar between two groups. We should pay more attention to fundus conditions, especially moderate myopia, and also should pay more attention on the regression for high myopia. And also, we should consider about the age-related decline in accommodation for the patients with the time flying after refractive surgery, no matter after LASIK group or SMILE group. Consider the changes in accommodative function for patients over 35 years old. We should offer them the customized refractive surgery design. Anyway, the patients age among the 18 years to 35 years with the high myopia are satisfied with the long-term visual outcomes after LASIK and SMILE surgery. Long-term follow-up for patients is critical to assess quality of vision, satisfaction, regression, tear film stability, retinal disease, binocular vision function, night vision, and corneal biomechanicals. We should provide a comprehensive vision care in order to protect the eyesight throughout the lifespan for these myopia patients.
Dear Chairman, hello everyone. It's a pleasure to have talk here. Today my topic is SMILE procedure and corneal biomechanics. I'm Wang Yan from Tianjin Eye Hospital, Nankai University, and Tianjin Medical University. I have no financial interest. As you know, for the laser vision correction, the most procedures are done on the cornea. After surgery, maybe have changed biomechanical property. There are some factors maybe affect the corneal biomechanics, such as different surgery procedure and the refractive power, cap thickness, side cut angle, and so on. So why? Let's show this example for different surgery. For the LASIK, we make the flap. We cut the surface of the cornea. However, for SMILE procedure, no cut for the surface of the cornea, just a small incision. So they will keep the surface intact. At the very beginning, we just wonder if the SMILE procedure will affect or more affect biomechanical property. We make a comparison. Within 3 months, we found no difference. However, after surgery, half years, we have a less after SMILE surgery compared with the LASIK, as SMILE procedure more stable in terms of biomechanical property. And after that, we make a model to find what is happened, and we found their stress and strain of the anterior and the posterior human corneal surface increase after SMILE procedure, especially for the posterior. And also we make a comparison with the LASIK. And in terms of the per unit tissue removed, SMILE seems to have a less effect on corneal biomechanics. And also for the size of incision, we found smaller of the size for the incision, maybe have a good biomechanical property. For optical zone, in general speaking, we like have a larger one because they will have a good visual quality after surgery. However, in terms of corneal biomechanics, we found the smaller optical zone has a relatively less biomechanical effect, so we should balance. And we have another study for the RST and the lenticle thickness. We found if have more than 140 microns, maybe CH and CRF may be increased repeatedly. This should pay attention to for this lenticle thickness when we do the surgery. The same situation would happen. So the smell was associated with less change in biomechanical property compared with femtosecond LASIK. Also, we found that there still have some relation with the complication during the surgery. For the OBL, we know that normally high energy have a serious OBL. However, we found the thick CCT, thick RST, and the stiff cornea may increase the risk for the OBL. And also, we have done another study. We found the corneal biomechanics affect surgical induced corneal high-order aberration after small procedure. And even for the clinical result, we found can affect by the corneal biomechanics. Compared to the baseline model used age, gender, and the preoperative refracted error, we found the biomechanical property may be induced some performance for the clinical result. Also, we have done a lot of research, experimental research with the tensile test and the inflation test. And we found slightly stiffer in the corneal vertical direction compared than the horizontal direction. And also there are some special cataract property based on the collagen fiber. And also here we done some inflation test use OCT. Also, we use FEM to make a comparison between the different surgery, and also we found here the small procedure is better than the LASIK procedure. And also we found the relation between the induced wavefront aberration on the anterior and the posterior corneal surface from this model. And also we have done some experimental research. We found even if we give the force on the cell, maybe the shape of the force will change. At the beginning have a longer and then got shorter, and also have a hypoptosis. Here is our publication on corneal biomechanics, clinical and experiment. So in summary, the different procedure may have a different result in terms of biomechanical property. We should pay much attention to when design for the procedure, such as incision size and optical zone, and so on. And also for biomechanics can affect the accuracy of the complication, such as OBL, and corneal biomechanics associates visual quality, and we should take care about predict clinical outcome for small surgery in terms of the biomechanical property. Thank you for our team and our co-worker. Thank you for your attention. Thank you.
I would like to thank the committee for this opportunity. Today, I'm going to talk about the proteomics and the neuromediator changes in SMILE and LASIK. In refractive surgery, the nerve transition resulting from the surgical incision and the laser leads to the disruption of the blink reflex and the lacrimal gland reflex. The transition of the nerve also triggers neuroinflammatory reaction and induce the release of neuromediators and cytokines. All these results in neuropathologic ocular surface changes, and the severity of ocular surface changes further affect the nerve regeneration as well as neuroinflammatory response. We conduct this randomized control trial and recruit 70 patients, in which patients' one eye was randomized to receive LASIK and the other eye to receive SMILE. We look at patients' corneal nerve status and the parameters using confocal microscope and the imaging analysis, patients' ocular surface assessment, and tear proteomics profiles. The ocular surface profiles after SMILE have been discussed by previous speakers. From our cohort, we found that SMILE has significantly more favorable tear breakup time, OSFOR and NEI score for initial 3 months time. Corneal sensitivity was also significantly better for initial 6 months. If we look at the time course in LASIK, tear breakup time still impaired at 1 year, sensitivity impaired at 6 months, NEI, OSFOR, and OSTI score at 3 months time, while all these parameters recovered to the preoperative level earlier in SMILE patients. On confocal microscope, we can see decreased nerve fiber density, fiber length, branch density, fractal dimension, and the increased tuberosity, presence of nerve speeding, sprouting, microneuroma are present in all eyes, regardless of the surgical type. And this is more obvious in LASIK patients. With time, we can see the restoration of the nerve matrix, but as you can see, it hasn't recovered to the preoperative level for both of the surgery, even in SMILE at 1 year time. When we quantify these nerve parameters, we found that LASIK patients had significantly worse nerve parameters in terms of the nerve density, length, width, area, fractal dimension through postoperative 1 year compared to SMILE. Furthermore, the extent of the corneal denervation is significantly correlated with refractive power we correct. The more refractive power we correct, the greater extent of corneal denervation patient would have. And this correlation is more obvious in LASIK patients. We further look at the neurobiological response on a molecular level. The red and blue dots in this volcano plot are significantly up and down-regulated proteins. We can see the number of these red and blue dots decrease with time, meaning the tissue reaction subsides with time. However, even at 1 year, there are still some molecules and reactions that significantly changes, which I'm going to show in the next slide. In early post-op period, in SMILE patient, the complement reaction, phagocytosis, inflammatory response, peptidic reaction are significantly activated. APOE and APOC3 that regulate the macrophage and NK cells are significantly expressed. Even 1 year after SMILE, there was a significantly increase of a wound healing and a peptidic reaction going on. We see MUCL1, which is associated with NGD, as well as CST5, which is a globally cell-derived mucin protein, are significantly increased even 1 year after SMILE. Interestingly, we found that higher level MUCL1 is correlated with patients' lower tear breakup time. Similarly, when we look at LASIK patients, during early post-op period, complement duration, immunoglobulin production, apoptotic duration are significantly increased. APOC family, such as APOC1, that plays an important role in inflammatory response, as well as HPA13, which is a stress marker, are significantly expressed. With time, these durations subside, but even at 1 year, we still can see not all the ocular surface proteins become quiescent. NUC5, AC1, and CST5, which has been reported as a potential marker for dry eye, are still significantly expressed even 1 year. And we also see flagrine also significantly decreased, which may explain the chronic ocular surface inflammation in LASIK. When we compare LASIK versus SMILE, these two procedures, we found that LASIK has significantly higher complement, acute inflammation, coagulation, wound healing, immunoglobulin activation, apoptotic, and phagocytosis variation compared to SMILE. And some of these significant variations, such as complement cascade, phagocytosis, and the ECN variation, are still significantly expressed in LASIK compared to SMILE even 1 year after surgery. Besides this biological response, how about those neuromediators such as substance P, NGF, CGRP that play an important role in nerve regeneration and neuropathic ocular surface changes? We found that NGF was significantly higher in LASIK throughout post-op 1 year, and substance P was also significantly higher in LASIK patients for initial 3 months time. This is because the greater tissue response I mentioned earlier on in LASIK amplify the neuroinflammatory reaction, while the level of all these triggering mediators are more stable in SMILE. We also found that the concentration of substance P was significantly associated with patients' peer breakup time and nerve fiber weight, and the CGRP concentration was significantly associated with ocular surface Oster staining, Schirmer value, and the nerve fiber density, length, and branch density. This suggests that by mediating or suppressing the neuroinflammatory response, it may improve patients' post-op ocular surface status. When we further divide these patients into high or low myopic treatment, we found that the increase of these neuromediators was significantly higher in high myopia patients. This finding is in support of what I mentioned earlier on the denervation status. The higher power we correct, the greater extent of nerves are denervated, and the resultant neurobiological impact is therefore higher. Hence, our future research may focus probably to investigate the potential strategies to mitigate neuroinflammatory response and to stimulate nerve recovery in these high myopia patients. The last part I would like to talk about neuropathic corneal pain, NCP. It occurs around 3% in our cohort, and what we found is these patients present with obvious neuroma formation at the end of the nerve ending, and they have these honeycomb appearances in their anterior stroma. Their TNF concentration compared to those without NCP was significantly lower. Take-home message. SMILE is associated with more favorable ocular surface status for early post-op period. After 6 months after surgery, we didn't see significant differences between these two procedures in the majority of the ocular surface parameters. SMILE has significantly better corneal nerve matrix than LASIK, and the denervation status has not recovered to a pre-op level, even 1 year after the surgery. The denervation is positively correlated with the refractive power we corrected, and this correlation more prominent in LASIK patients. We still see significant differences in neurobiological response between these two procedures, even though patients' clinical symptoms and the sign of ocular surface have subsided and become comparable. High myopic correlation leads to greater neuroinflammatory reaction, and this reaction is significantly associated with some clinical ocular surface parameters and the corneal nerve status. Low tier NGF level may be associated with postoperative neuropathic corneal pain. Thank you for your attention.
Great. Okay. So I'd like to thank all the speakers for their fantastic talks. We've seen a whole range of SMILE from all the way from techniques to nerve regeneration with dry eye assessment, and also all the way up to some long-term assessments as well. So we just have a few questions that I think we can go to from the chat as well. So I'd like to first of all start asking Professor Wang. Professor Wang, you talked a lot about biomechanics and showed some excellent work that you've done in this area. One of the questions was, is how much of an RST, a residual stromal bed, is considered to be safe in SMILE? what sort of guidelines do you follow for your cases? Thank you. Professor Wang, you're on mute. We can't hear you.
Okay, thank
Great.
you.
Thank you.
Thank you, Professor Jamata. Yeah, that's quite a good question. Actually, clinically, everyone just wonder how much we should keep for the RST. Actually, we have done a lot of research. At the very beginning, maybe 10 years ago, we just start for the small surgery. We just keep the for RST for small surgery, maybe about 300. Yeah, we just wonder, we just worry about maybe have some something will be happen for keratoconus, such as. But later on, we found maybe a small surgery is more safety compared with LASIK. Just the presentation you just mentioned. And also I found Professor Lin just show us his 215. Actually, now at the moment we have about 280. Yes, 18. Because I found actually, when we do the surgery, two things we must maybe we have a consideration. One is RST. Another thing is PTA. PTA is SP means percentage. T as tissue and H ablation alter. That's PTA means how much we will give the tissue ablation. So we normally for the LASIK, we just keep the PTA about 40%. For small as just like 40%. So another thing is we just thinking for the whole thickness of the cornea. If the cornea, the whole the thickness of the cornea is too thin, we just maybe be careful about it. If the thickness is thick enough, we think it's okay. Recently, we have done a lot of research compare for the different small procedure with the covered ST, you know, which can make measurement for the mechanical property. We found if the we have a more tissue ablation, more tissue extraction, maybe have change a lot of the correct ST, especially for DA ratio. You know, DA ratio, a special parameter for the cornea. So we think maybe another percentage is just thinking as 30% if we have the whole tissue ablated, means for the whole thickness of the cornea. So I think the more important is how much for the LT, the lenticle thickness. If the more lenticle thickness, we should keep LT, the smaller is smaller.
Good. Yeah. Okay, thank you. So I think Professor Lam posed a quite an interesting question about where we think, I mean, SMILE or lenticle extraction has been around now for almost 10 years. Obviously, we have to think about the future, and we have to appreciate this is probably what we consider to be a first generation procedure. So Kelvin, I just wanted to ask, I mean, with your experience, where do you think, what would you like to see can be an improvement on second and third generation SMILE or lenticle extraction?
I think one of the work that a lot of people have done is to optimize the outcome of astigmatism. So I certainly agree that incorporating the cyclotorsional adjustment in future SMILE devices would be an advantage in perhaps improving the outcome of astigmatism.
Okay, yeah, I think that's a good point, and I think Professor Lam showed that with docking and then rotating, which is what I do as well. It can be, I mean, in his video is very good, but I can see a lot of people maybe making mistakes when they're trying to rotate the cone, or maybe even getting suction loss when you basically have to rotate the thing. I think one thing that is difficult to do, I think, with current SMILE is understanding fixation onto angle kappa. Because often if you try to decenter to angle kappa, you may increase your risk of basically getting suction loss, because of course it's something we all basically want to worry about. So I don't know, Professor Lam, do you want to make a comment about that, about fixation? Because some of the newer devices, some of the newer machines that are available on the market now will allow you to change the fixation on the screen once you've done the docking as well. But can you just mention about how you do your fixation with respect to the center of the cornea and angle kappa?
Yeah, I think fixation is very important. We have this angle kappa, so we look at the the water mask, see whether you get a good circle or not. I think in future, probably if we have tracking and other locking system, so that we may be able to do it in a more accurate manner instead of just using our human eyes.
Yeah.
So this probably will be one area that more research and development is anticipated. By the way, I think we have a wonderful sections, and thank you so very much for Joe, Kevin, and Professor Wen for moderating this section, and all the wonderful speakers. In the interest of times, because we are already a little bit over time, so we would like to thank everybody once again, and then we would like to move on to our next sections on ICL. Thank you so very much.
Thank you. Thanks.
Thank you.
Thank you.